Good morning, everybody. Welcome to Semel Grand Rounds. My name is Eric Chung. I'm the Chief Medical Officer for the UCLA Resnick Neuropsychiatric Hospital, and I'll be moderating today's talk. Very, very pleased to welcome and to introduce to you Mr. Gregory Smith from Pennsylvania, who will be giving us a talk on his recently released paper in Psychiatric Services, which was titled Effects of Ending the Use of Mechanical Restraint and Seclusion in the Pennsylvania State Hospital System between the years of 2011 and 2020. A little bit more about Mr. Smith. He's an international consultant on psychiatric and behavioral healthcare services, with special emphasis on the non-restraint approach to care and services. His work includes staff training, case review for legal proceedings, expert witness testimony, advocacy, facility monitoring, and response team development as a non-offensive or non-violent positive approach to supporting people who are in crisis. This work has spanned the last 30 years, both in public and private sectors. He has published many works as lead author of several studies that examined especially the transformation of the Pennsylvania State Hospital System and its use of containment procedures over the past 30 years. In October 2013, Mr. Smith received the Netherlands Johan van Duren Award in recognition of his leadership to that country's work at reducing its use of containment in these settings. And during his career, Mr. Smith was the CEO of Allentown State Hospital, of Mayview State Hospital, and the last CEO of Harrisburg State Hospital up until 2006. He was also the director of the Whitehaven Center, a large facility that supports people with intellectual and developmental disabilities. Since the fall of 2015, Mr. Smith has been a consultant and advisor to the World Health Organization on mental health recovery and the non-restraint approach to care and services. So I'm pleased to hand this off to Mr. Smith, who will introduce a few of his colleagues who are here with him today.
Eric, thank you very much. I trust everyone can hear my voice. I want to begin by thanking the Institute for Neuroscience and Human Behavior at UCLA, in particular Dr. Jonathan Help, for inviting us here today to present the results of our study to all of you. I'm speaking to you from Mountaintop, Pennsylvania, which is more or less about 100 miles due north of Philadelphia and about 75 miles east, that'd be west of New York City. Also presenting with me today, who's going to give you the results, our civil hospital results, is David Markley. David is the Chief Executive Officer of Warren State Hospital in Warren, Pennsylvania. And Marcy Hepner. Marcy is the Chief of Performance Improvement at our largest state hospital, Torrance State Hospital in Torrance, Pennsylvania. Let me jump into my slides at this point. This is the paper we're here to talk about today. It was published in July 2022 in the early release of the Psychiatric Services Journal. I expect it'll be in the print edition beginning tomorrow. And I also want to give attribution to Dr. Aidan Altenor, Roberta Altenor, Dr. Robert Davis, Bill Steinmetz, Dr. Dale Adair. Dale is the Chief Medical Officer for our state hospital system. Donna Ashbridge, John Deegan, Kristen Clement, Marcy we already introduced, and Elizabeth W. Smith. This is the paper of the information we're going to cover today. I also want to acknowledge the thousands of state hospital workers within our Commonwealth, specifically the security staff, psychiatrists, nurses, medical doctors, program staff, for all the work they have done in over 25 years, close to 30 years of our Commonwealth's efforts to decrease our use of containment procedures and eventually eliminate them. For the purpose of this presentation and all the research we've done, we have no financial relationship with any commercial interest or governmental grant. The objectives we've already covered. Ladies and gentlemen, I'm going to probably blow by some of these largely because I want to get to the meat of the presentation, which is what Marcy and David are going to talk about. These are things we hope to cover today. So those are the educational objectives there, and they were covered in the flyer that went out to everyone. I want to start off by showing everyone some news accounts of what's been going on. If you were to Google restraint death, you will pick up these types of incidents through Google News accounts. And you're going to see a common thread with all of these, which is that the lion's share of these incidents that are reporting death are death from prone restraint. This is a recent one from last year, January 21, 2022, complications of cardiopulmonary arrest sustained after physical restraint in the prone position. This is a Michigan ban on restraints at facilities in the Cornelius Frederick School District. Again, another unexpected death. This is a state hospital death and restraints and seclusion in Texas, Austin. The sad fact with Justin's death, Justin Reeder, which occurred this past September, is not only was he in mechanical restraint at the time of death, but Justin was in seclusion. And he is someone who was diagnosed as being on autism spectrum disorder, ASD. And then finally, this is not just about patients and consumers, this is also about direct service workers who have died while applying physical restraint. This particular person, Matthew Barron, this is from 2012 at Oregon State Hospital, died while applying physical restraint to one of the patients in that hospital. The point of this is that because of the unpredictable nature of psychiatric and behavioral events, the use of seclusion and restraint are the most dangerous procedures direct service workers can use in any healthcare setting. For the purpose of this presentation, we're defining physical restraint as any hands-on containment or control of a person. Seclusion, basically locking a person alone in a room. Mechanical restraint is the use of any device. And containment procedure or containment procedures are all of the above. And then chemical restraint is any unscheduled use of a fast-acting medication that produces sedation. The Centers for Medicaid and Medicare Services, as well as the Joint Commission, require a medical doctor or a certified registered nurse practitioner to write orders for the authorization or use of any of those procedures. It's important for agencies to realize that there are a lot of moving parts in any large healthcare agency. And certainly financial outcomes, admissions, discharges, readmission rates are all some of the most common measures used to assess the effectiveness of a hospital. And this is my personal view, but I believe that there's no greater measure of an agency's effectiveness, a state hospital, and in any inpatient psych setting, than its ability, it's the manner in which it supports people in crisis. The World Health Organization has waded into this issue some 15, 20 years ago, basically saying that they violate many human rights, the right to be free from violence and abuse, and the right to be free from torture and cruel, inhuman, and degrading treatments. In the year 2000, the Pennsylvania State Hospital System received an Innovations in American Government Award for its seclusion and restraint reduction program, which started us on the road to doing a much better job of measuring, and reporting our use of containment procedures and all of the safety measures associated with their use. This paper here has become the seminal work on the use of these procedures. This was published in 2005 in the Psych Services Journal and has been referenced more than 250 times now, and was a retrospective study that looked back to starting in year 1990 on our system's use of seclusion and restraint. This particular paper, we exclusively looked at the use of unscheduled medications, PRN medications, that led to a decision system-wide to end the use of PRN orders for psychiatric and behavioral indications. And it occurred over a 18-month period, if I remember correctly. And this particular paper reports on the effects of that change on specific patient and staff safety measures, particularly assaults, aggression, medication errors, and restraint and seclusion use. This is the 2015 paper published in the same journal that looked exclusively at the civil hospitals going from 2001 through 2010. This paper here, published in the December of 2015, looked at the forensic centers, exclusively at the forensic centers from 2001 to 2010. And that brings you up to date with our current paper that looks at 2011 through 2020. This particular slide shows that during this window, 2011 through 2022, the hospital system used seclusion only 4 times. That's civil and forensic. Mechanical restraint was used 128 times during the same window and was last used in September 2015. In 2020, physical restraint was used 910 times in the hospital system for a total of 2,086 minutes. So our study objectives with the current paper that's in front of you that we're talking about today was to look at what happens when we stop using those procedures, specifically on aggression. And aggression, for the purpose of this paper, is defined as threatening behavior, a threat of harm to other patients or staff. We looked at physical restraint, the effect of ending the use of mechanical restraint on physical restraint, and we were very concerned and measured the effect on patient-to-patient and patient-to-staff assaults and self-injurious behavior. And finally, we looked at our use of stat medication orders during the same window. Pennsylvania State Hospital System, for those of you who don't know about, during this window comprised 6 separate state hospitals and 2 forensic centers. The hospital system also includes a sexual responsibility and treatment unit on the grounds of Torrance State Hospital and a long-term care facility at South Mountain. Those 2 programs have never permitted the use of seclusion and restraint, and were not part of this study. Methodology, very quickly, we collected data on 68,000 incident reports, including 9,500 incidents of physical restraint involving 1,800 unique people. The data was calculated per 1,000 days of care, which controlled for our changing census within our hospital system. It assessed the incidence of assault, aggression, and self-injurious behavior, and the use of physical restraint during the decade. We also controlled for the demographic and diagnostic differences, which we did a deep dive into in the papers, but will not cover today because of the limited time. These are where the hospitals are located. I don't know if my cursor shows up. David is up here at Warren. Marcy's at Torrance. I'm somewhere in here. And of course, you have the Philadelphia Eagles and the Philadelphia Phillies in the lower right-hand corner. Pennsylvania census is about 12.7 million, roughly 1/3 of California. I think you guys are up at about 40 million. Our census during this time, or actually the last day of 2020, was 1,000 people in our civil hospitals total, and approximately 250 people in our forensic centers. Our state hospital mission statement, I don't think, is any different than what you have in California, which is to care for people whose behavior is so dangerous or socially unacceptable that their communities cannot tolerate their presence and no one else will work for them. As a system of care, we are an adult system. We do not serve children. People are typically 18 years of age or older. The civil hospital census during this time averaged about 915, forensic 250. During this 10-year period, we provided almost 5 million days of care within our hospital system. Less than 7% during this time of the people we served had an intellectual or developmental disability, and roughly 780 admissions, 920 discharges. 40% of all people served in the civil hospitals during this time had a positive criminal history. Typical staffing for any unit in our state hospital system, which has largely not changed in 20 years, is the team, a unit supports up to 28 people. It's led by a psychiatrist or certified registered nurse practitioner, 3 to 4 direct care staff on the first and second shift. In addition to them, you'll have 1 to 2 nurses on the first and second shift, and they're supported by a social worker and a psychologist. Most of the off-unit program up to the point of COVID was off-unit. COVID changed that a lot, and maybe David and Marcel will go into how that has affected their services. We have a doctor or a certified registered nurse practitioner on each hospital campus 24/7. State hospitals, when you look at specifically injuries to staff, they can be explained, or what we found during our 25 years of looking at the data, as an unexpected or unforeseen patient behavior. The second most common is attempting to stop or respond to an assault, peer-to-peer, patient-to-patient, or patient-to-staff. Responding to or preventing a person from injuring themselves. And then finally, applying restraint or placing a person in seclusion. The point being, ladies and gentlemen, that if you can push on your use of containment procedures, you'll see your staff-related injuries from an assault go down. I need to move on. I want to push off and let David talk about the civil hospital results. David?
Looking at the civil hospital results from the years 2011 to 2020, the use of mechanical restraints, as Greg mentioned, was 128 during the decade, with a total of 16,611 minutes, or 276.9 hours. The last use of mechanical restraint in the state hospital system was in 2015. Seclusion was used a total of 4 times for a total of 189 minutes, or basically 3 hours, during the last decade, and the last use occurred in 2013. Physical restraint use was significantly declined during the decade from a high of 1,077 events in 2013, which figured out to about 2.56 per 1,000 days of care, to a low of 380 times in 2018, or 1.05 per 1,000 days of care. From 2011 to 2020, it was used 6,972 times, involving 31,916 minutes, or 532 hours of physical restraint. One of the things that happened in Pennsylvania, we had some changes in how we looked at the length of time for physical restraint. We'll talk about the 3-minute rule as we get further into it. But the duration of physical restraint declined from an average of 6.6 minutes per event in 2012 to under 3 minutes per event between 2018 and 2020. The use of stat medication for psychiatric indications did not change, averaging at 18.2 per 1,000 days of care. Our definition and the way that we captured data for patient-to-patient and patient-to-staff assaults did not change during the decade. Our incidence of aggression did not change during the decade, and we averaged about 3.9 per 1,000 days of care. And our self-injurious behavior did show a significant decline during that period of time. Thank you, Greg. Looking at the line graph here, what you see is a decline in seclusion and mechanical restraint, as well as a decline in physical restraint across that period of time. We do, at the bottom there, show the seclusion and mechanical restraint as much smaller numbers compared, of course, to our physical restraint numbers. Our physical restraint numbers are a little more active, and we did see some peaks that occurred towards the end, towards the middle there of 2020. And a lot of times when we see those peaks, we're able to trace those back to a very small select group of inmates that tend to drive our data. But in general, we saw a pretty significant drop in use of all containment procedures. Reasons for physical, for actually having to have physical restraint or hands-on or seclusion episodes, these were the behaviors that the patients engaged in. Your top line there looks at patient-to-patient assaults, and the reason why that's so elevated when compared to other events is that in the Pennsylvania State Hospital System, for a patient-to-patient assault, it results in 2 incident reports for every event, because it's usually 2 actors engaged in the altercation. So that's why that number looks elevated. That's why that particular line is so much separated from its cohorts there. But our patient-to-staff, our self-injurious behavior, and our aggression numbers are all there in that cluster at the bottom, and all of them show that decline moving up into 2020. This shows our rate of patient-to-staff assaults for 1,000 days of care between 2011 and 2020. As you can see from the trend line there, there's a really small decrease over the decade. In general, those numbers have stayed fairly consistent with the peaks and valleys based on the population in-house, but the numbers themselves have stayed fairly static. Looking at average time in physical restraint per event from 2011 to 2020, you'll notice the sharp decrease in the trend line there. And as I mentioned, at one point in time, Pennsylvania made a move from a 10-minute time limit to a 3-minute time limit for physical restraint. That accounts for some of that rapid decline, where we see that really sharp decrease in the amount of time that patients spend in physical restraint. This slide shows the incidence of aggression for 1,000 days of care. And again, what you're seeing with the trend line there is that we show kind of a gradual drop across the decade, with the numbers being fairly consistent across that line. We did see a rather impressive dip in 2020 for aggressive behavior. And that's was one of the things that we want to talk about as far as changes that we saw as a result of COVID. We actually expected to see tremendous spikes in some of our data as a result of COVID, and the fact that patients weren't able to get out and do some of the things that they've been able to do. And we actually did not see that. We actually saw aggressive behavior kind of drop. A lot of folks were stuck in units or on units for long periods of time, and some of that behavior just kind of faded away. They spent more time doing other things. Okay. And this last graph here is, is the physical restraint for 1,000 days of care. And again, you're seeing that gradual decline across the decade, with the spike around April to July of 2020. And again, when we looked specifically at those numbers were representative of a very small select group of individuals who really drove our data. We had some pretty aggressive cases at that point in time, which were kind of driving some of our physical restraints. But in general, across the hospital system, we've consistently seen that decrease. And then this busy little slide talks about the use of stat medications for psychiatric indications for 1,000 days of care. If you look early in the, between 2011 to 2013, 14, you see a lot higher use of stat medications and stuff. We were really drilling down and focusing on the use of stat medications. We don't use PRNs in the state hospital system, so all medications had to be ordered stat. And we were really drilling down and trying to find out why some of those numbers were high and getting those numbers down. And so what we've managed to show is some fairly consistent across the board, but some of those peaks, some of those spikes got kind of pulled down in where the rest of the groups tends to be. So, okay, Greg, I'm not sure if Marcy's able to get on or not, if she's been able to hear. I've been communicating with her. Marcy, are you there?
Can you all hear me?
I can hear you, Marcy.
Okay, I'm not sure what's going on with the video. My screen is green, but I'm not visible, it appears. But I'll gladly talk through some of these slides with you all. Dave, I did want to share with you that you might have made a little bit of a faux pas there. You mentioned that the inmates, your DOC time is showing. I'll just speak for Dave. Both in the forensic centers and the civil setting here in our state hospitals, we don't serve inmates. We serve patients and residents in our programs. So I just wanted to take a brief second and acknowledge that. I had the privilege of being the Forensic Center Chief Executive from 2008 to 2016 during a rather tumultuous time when we were relocating programs and really trying to change a culture. When we talk about changing culture, we really talk about the whole gamut, from the leadership to the frontline staff to the perception of the people that we serve. When we're talking about things like mechanical restraint and coming from a correctional type approach for some of the staff that had been working in these facilities, we were thinking we weren't doing too bad with using the mechanical restraint about 10 times for the decade for a total of 432 minutes or 7.2 hours. And the last one that was used was in 2014. As Greg has mentioned and as our papers have mentioned, we all felt that we could do better. We know that staff get injured. We know that residents and patients get injured. When you are hands-on, that's the most difficult time and it's the most critical time. So we really took a deep dive looking at our data and measuring everything. Seclusion was only used once during the decade in 2012 for 345 minutes for a total of 5.75 hours. These were very unique and rare circumstances. Physical restraint was used a total of 2,456 times, involving a total of 8,606 minutes. And I guess, you know, from my perspective, we're throwing a lot of numbers at you, but for us, the overall picture was that it can be done. And if you look at it over time, you'll see the gradual impact and you'll be surprised at some of the outcomes. The duration of the physical restraint events significantly declined from 6.8 minutes per event in 2011 to under 3 minutes per event between 2017 and 2020. Dave mentioned that we went dramatically from 10 minutes to 3 minutes per curriculum. In the Commonwealth of Pennsylvania, we do vendor contracting for our crisis intervention types of services. And the program that we were contracted with, their only permitted use of physical holds could not exceed 3 minutes. So we as a system adopted that philosophy and really had to do a lot of work. Our staff were fearful that there would be more injuries, there would be increased numbers of events, people would become more violent, it would just be total pandemonium and mayhem, which we were pleasantly surprised that that was not the case. We had also looked at the stat use of medication for psych indications, and again, remember, we don't use PRNs in the state hospital facilities here in Pennsylvania. We only use them for psychiatric indications. And it went from 10.1 per 1,000 patient days, with that number being a total of 761 in 2011, to 7.06 per 1,000 patient days, with that number being 743 in 2020. Patient-to-patient assault significantly declined from a high of 13.2 in 2012 to 7.62 per 1,000 patient days in 2020. Again, looking at those numbers and being pleasantly surprised. When we look at patient to staff assaults, significantly declining from 206 per 1,000 patient days to 1.26. And again, with incidents of aggression and SIB declining as well. When you're looking at the physical restraint events per 1,000 patient days, again, you're seeing a gradual decline. And as Dave had said, when you look at those peaks, we were able to zero in on those and determine that it was due to a select few individuals that were really not doing well during that period of time. On all of these slides, you'll notice that in March of 2020 is when COVID began for our data collection purposes, and we were able to realize that there were a lot of decreases counterintuitive to what we had anticipated. Our staff actually anticipated increased numbers as well as the leadership, but actually over time the numbers did decrease. One of the other things that we've noticed as we were collecting this data for these studies over the length of time that we did is that it's really important to measure everything to make sure that you are able to capture the full picture and not just select segments of what you're looking at. And one of the things, what do you do with all that data? Well, you use it to educate staff. Here's a clear indication that the numbers actually decreased over time. Go ahead, Greg. When we're looking at our service monthly rate of physical restraint and duration of hours in that period of time, the numbers look a little scattered all over the place there, but if you look at the linear numbers for both physical restraint per 1,000 patient days and the total hours, you'll see that gradual decline again. And you're seeing that also that a little less than 3 minutes and a little less than 2 minutes. With looking at the patient and patient to staff assaults, here we have bargaining units that are doing the frontline work, and a lot of times they're wanting to see how effectively we are using our intervention techniques so that our staff are safe, and we are able to demonstrate that very significantly here and continuing to use safety and not wanting our staff to be injured as a priority for our hospital facilities. And remarkably, looking at the incidence of aggression and self-injurious behavior, we're seeing just incredible decreases. Again, with those spikes, we're able to zero in on that. We're using some real-time data to look at weekly, monthly, daily at times use of additional medication for psych indicators and aberrant behavior to help us zero in on what we need to do for those patients. Our physical restraint events per 1,000 patient days, again, we have a few spikes there in mid to late July of 19 and October of 19, but again, those are the gradual decline over time is what you want to look at. It's sort of like investments over time. Can't look at it on a daily basis, you got to look over time. The Torrance versus Norristown stat med use for psych indicators, the two psychiatric centers that have, the two state hospitals that have forensic centers, we did a comparative between the two, and we were able to see that kind of converse data that showed some spikes in certain areas and some gradual decline for Torrance, but a little bit of an increase for Norristown. So we use those as a comparative to work with each other in our sister facilities and perhaps look at some collaborative efforts in dealing with particular types of individuals. So Dave, you want to take it from there?
Sure. I'm going to go through these last couple of slides rather quickly. I'm sensitive to time, and I know you just want to have time for Q&A. So the state hospital policy on the use of unscheduled medications, again, we've mentioned this before. We don't use PRN medications for psychiatric purposes. We only use stat medications that requires the doctor to provide a face-to-face assessment, write an order. They can do verbal orders and phone orders, but they still have to appear, they still have to assess, they still have to evaluate, so they can't have standing orders for PRNs. Back in 2009, the PA hospital policy on seclusion and restraint was put in place that prohibited the use of floor control, both prone or supine, limited mechanical restraints to 10 minutes. We've talked about the 3-minute rule that came in place in 2017. No chemical restraints. The doctors had to write the orders for seclusion or mechanical restraint. They were limited to a 30-minute time period. And we did establish no restraint lists for our patients. With the 3-minute rule in 2017, part of that, as Marcy mentioned, had to do with the vendor we were using for crisis intervention purposes. And when asked why they limited it to 3 minutes, if you look at what professional wrestlers do, high school wrestlers, pro boxers, pro wrestlers, people that are in much better condition than we are, they do 3 minutes and then they're pretty much done. They take a break. So they thought it would be safer for all concerned if we limited it to 3 minutes. And we actually did see a lot of real positive results by doing that. Go ahead.
I've lost control
You
of
look
the
at other
slides.
changes that account for the decrease. Okay.
Ugh.
Other changes that have come into play that support the changes that we have had over the last decade. We have a different approach. We have a recovery approach to psychiatric care, which started in the late 1990s that talked about hope and resilience. The state policy on containment changed 4 different times between 1998 and 2009. We appoint people that support a non-restraint care and service mentality. We discontinued the use of PRNs. Most of the hospitals also adopted what we call a PERT team. It's the Psychiatric Emergency Response Team. This was based on a model that came out of Allentown. And for Warren, it actually kind of coincided with our last use of seclusion. A PERT team is actually a group of individuals that are specially trained in the facility. So when you have a situation that's starting to unfold, so we're not talking about a full psychiatric emergency at that point. This is something that can go in proactively and intervene when the incident is small before it gets out of control. And we've had a lot of really good results because of that, because we can get in when the situation is still manageable and before it becomes a problem or becomes something that requires a code or an all-call kind of response. Other changes, the use of clinical alerts, a unified workforce. We started using DBT in 2003 for some of our units. I mentioned the do not restrain list. We've also adopted the use of wellness recovery action plans and psychiatric advance directives. Our current focus is on trauma-informed care. So a lot of the do not restrain lists have kind of gone out the window because under trauma-informed care, we don't use a lot of restraint. We don't use mechanical restraint. We don't use seclusion. And most of the hospitals have a treatment mall for providing services. Conclusion is that the study provided compelling evidence that the use of seclusion and restraint can be reduced or eliminated, both in civil and in forensic populations, to the benefit of both persons being served and their support staff. A key change during the 10-year study was the reduction in the maximum time spent for physical restraint from 10 minutes to 3 minutes. Additional contributing factors included recovery-supported clinical approaches and continuous adherence to the 6 core strategies for seclusion and restraint reduction. And now I guess we can open it up for questions.
Thank you, David, Gregory, Marcia, for sharing with us the data of an impressive body of work over decades to get to zero seclusion, zero restraint. And you've showed us what are some of those consequences related to patient behaviors, patient to staff assault, et cetera. I'll lead with the first question for you to answer as a group. And I'm going to first quote from the 2005 paper that you published, where it said, staff arguments at the unit level for and against the use of restraint, sometimes during the crisis itself, were common. And I think that makes a lot of sense to folks listening here who may have the belief that restraint and seclusion are needed to keep people safe. So the question is, how did you do it? Especially at a frontline staff level, what really made the difference?
Well, since I wrote that, I'll go first, David. Response teams, PERT teams were key in turning that page at every hospital that I worked in. PERT teams, by the way, do not get paid extra money to function on a team. It's an all volunteer force in the Pennsylvania State Hospital system. It's social workers, it's psychologists, it's direct service workers whose only job is to report to the scene of a crisis, where a successful PERT response is when they don't have to do any hands-on. So their mission is to de-escalate the crisis from occurring. They take control of the crisis. If the doctor or the nurse practitioner orders restraint, it's taken as at least back at Allentown, is that they were authorized to use it if they needed to. So everyone at the scene took their key from the PERT captain. And Eric, these were men and women who were the most experienced, had the most credibility in de-escalating a crisis. So they went a long way. And then they would provide feedback to the treatment team on what they learned when they were doing the debrief with the individual post-event. In other words, lessons learned from it.
And can you describe further, is there a specialty training? Is there something unique about the training the PERT team members received that you would share?
At Allentown, and David can speak for Warren, the PERT team at Allentown, they were the staff development specialists. They were staff who had bought into the approach, the nonviolent approach, and they presented that message wherever they went. It really was a big culture. They led the culture change at Allentown. David, you want to add to what you saw at Warren?
Absolutely. When we started a PERT team here, again, it was after an event that we were asked to look at instituting a PERT team, and our group was purely voluntary. People were kind of selected based on their skill set, their ability to verbally de-escalate people, their empathy, their willingness to go in there. And I think for a lot of the folks, what it was the ability to take the time to handle it safely, to treat the patient with dignity and respect, and to let the patient know that they were safe. I think pre-existent to that, a lot of times when there was an all call, it was kind of an all hands on, and people rushed in with the anticipation that they were going to be engaged in a physical restraint. So that became almost a foregone conclusion when they had a code orange. With PERT, it became a different approach. It was, let's see if we can solve this without having to get to that point. And sometimes they took much longer. Absolutely. A code orange or a crisis call could be over in a few minutes, whereas a PERT call, it could take a longer period of time because you have to actually work with the patient and help to de-escalate them. But once that started working and started bearing fruit, and the team started seeing that work, then we did a lot more training on the non-physical interventions, a lot more training on verbal de-escalation, distraction, other things that they could do that would be effective rather than jumping right into a hands-on thing. And despite everybody's beliefs, we did not see an increase in assaults. We did not see an increase in staff injuries. We actually saw people, we saw that decrease, and that kind of was the payoff that got people invested in that process. It has to get refreshed from time to time, but that's kind of the focus that we've used, and it's worked pretty effectively.
You've described a few of the different elements, the PERT team being one of them. Another thing that was touched on was the use of medications, or the disallowance of use of different types of PRN medications. Can you elaborate a little bit more about what exactly happens in a acute clinical or behavioral situation, and what meds are administered, if anything?
I can tell you that at least here at Warren, if we have a crisis, and we do have crises, and they'll get called, sometimes we'll do a PERT call, which will predicate that if we have the time to proactively try to resolve the crisis. However, if that doesn't happen, or if it's not successful and a code gets called, or if there is a need, a lot of times the doctor will suggest medication. They may suggest to the patient, the opportunity to take either medications early or to take an additional dose of medication, a stat medication dose. Sometimes the patients are willing to do that, and that helps to de-escalate that situation at that point. If it is necessary, we can do a hands-on to administer medication over objection and those kinds of things. But generally speaking, those are things that the doctor has to be fully aware of the circumstances and make a decision on if that's the best practice to engage in. Most of our doctors are incredibly conservative with the use of medications. So giving stat medications is not something that puts anybody at risk. We also are very careful that we don't have, back in the bad old days, they used to have cocktails and stuff like that that actually resulted in chemical restraint. That stuff has been is stuff we haven't done in years and years and years. So it's very selective, it's very careful, it's very calculated if they use stat medications.
Yeah, Eric, as I see the questions popping up here, I don't want people to leave with the impression that we don't use medication on a stat order basis, because we do. We collect data on it. And I want to inform everyone that we have not stopped collecting the data. If you Google Pennsylvania State Hospital Risk Management Summary Report, what will pop up is the state webpage that shows you month in, month out the reports that are generated, so anyone can see what we're doing. We're that transparent in our state hospital system. And included in that are the medications for psych indications given by stat physician's order. I could be wrong, but I think it's on the last page of the report.
You're correct.
So we still give them, we still collect the data, and you can see what we're doing month in, month out by facility. Eric, next question.
Yeah, thank you. A lot coming in, and we'll try to get to as many as we can. Here's a question. What are your recommendations to the clinical and executive leadership teams of systems, healthcare systems, who are faced with the need to reduce injuries, improve patient outcomes, and at the same time face workforce or partners that might be resistant to change?
I would tell anyone who would listen to my message, embrace psychiatric emergency response teams. My belief is every one of your hospitals have a response team. As I've traveled the world, everyone has their code white or their code orange protocols. What's different in Pennsylvania is that they are used to de-escalate the crisis. If they can successfully talk a person down without taking them down, then everyone wins.
I think your 2005 paper referenced other components that were put into place, including the use of peer supports or mental health workers with lived experience. Can you elaborate on that and how those were deployed in the hospital, how that contributed to any change in culture, including trauma-informed care?
David, you want to take that one?
Sure. All of the hospitals have at least one, if not more than one, peer specialists that are hired employees of the state hospital. One of the conditions of their hiring is a lived experience with mental health issues and stuff like that. So they have that kind of boots on the ground knowledge. They've experienced, and they are very active with the patients. They're involved with the patients. They do groups with the patients so that the patients get to know them. They get to understand what they're all about. They also have that connected shared experience, which gives them a little more credibility. And this is some of the information that the peer specialists will share with the patients, because just like we share data with you, we share data within the hospital. So it's something that they see, and they see the efficacy of PERT teams. They see the efficacy of doing good crisis intervention that doesn't require hands-on, and that dignity and respect. So we see a lot of that coming through in that educational component from the peer specialists, as well as the rest of the staff. This is something that we really strive to teach the staff as we're going through crisis intervention, and that kind of importance of, if you have to use that technique, there's all these other techniques we can use before we have to get to a hands-on. So we have a whole lot of other kinds of responses that we try to teach people, including the peer specialists, so that we can do other things before we have to go to a hands-on. We've got a lot more options to choose from.
You've been describing the PERT team as such a key component in here. Has come up multiple times. A question came up if you make available any type of training manuals or information for other hospital system to consider.
Sure. If they want to contact me through my email address, I can refer them to at least one group that I know of that does effective PERT training.
Another question, this one's more of clarifying to understand the populations that were served in your facilities. And I think it's a combination from different folks here. So one is, what is the mode of arrival? Are these individuals who have been already hospitalized in another facility and are then transferred to you? Do they come in direct presentation from 911 or emergency response into your facility? Can you answer that?
People who have come into the civil hospitals were, in almost every case, there may be exceptions, were previously served in an acute care hospital. People coming into the forensic center, and correct me if I'm wrong, Marcy, have active crimes open against them for the most part, and were previously served in a jail, prison, or local correctional facility. And that is a separate system. People with a forensic commitment are not on the same unit as a civil patient. So yes, people coming into the civil hospital were transferred from an acute care facility. The services in the Pennsylvania State Hospital system are acute beds, acute and subacute.
Going back to your 2005 paper for a moment, which I think really even provided what some might call a roadmap. You mentioned that it's a seminal paper. It's been referenced many times. In that paper, it described key thought leaders. I think the gentleman's name was Sophie, and declaring that restraint was a treatment failure. Can you elaborate on what was the role of kind of philosophical change or culture change from that?
Well, that quote is attributed to Charlie Curie.
Curie, sorry.
Yeah, Charlie was the SAMHSA director for, I think, 4 or 5 years. And while he was our commissioner, our deputy secretary for mental health, and Charlie, in my humble opinion, was the one person who backstopped all of these changes during the late 1990s, early 2000s. So when people were pushing on our use of seclusion and restraint, clinicians who believed they were important to be used, Charlie challenged the system not to use these procedures. And that phrase that they constitute a treatment failure, I think is very true today. There's no evidence to support the use of seclusion and restraint. They're not therapeutic. There's been no study that I've seen, Eric, that demonstrates the efficacy of using those procedures. Largely, the risk management reports are the front page news headings, some of the ones I talked about on the front end of this presentation. People are getting injured, people are dying.
Yeah.
So we believe restraint and seclusion use is evidence of a treatment failure and can have a long-lasting effect, including trauma, severe injury, and death for both the people you serve and the staff that support them. Finally, in many areas, prolonged exposure to seclusion and restraint, if you look at what the World Health Organization has stated, could be considered torture.
Yeah.
So it's out there. We're pleased to be able to publish our results, and I give, starting with Charlie Curie, a lot of credit for, helping backstop the change we were trying to make when people were questioning, the culture change. Someone has asked about the culture change, and the current policy in Pennsylvania is you can use mechanical restraint, you can use seclusion up for a half hour, and you can use physical restraint, what is it, David, 10 minutes. And hospitals, all 6 of them, including the forensic centers, starting in 2015, 2016, change their local hospital policies, potentially in conflict with what the state policy is, to do away with those procedures. That, to me, is evidence of culture change.
Greg, David, Marcia, I just want to thank you for sharing your experiences with us. We're reaching the end of the hour here. We caught a lot of the questions, not all of them, but I think we're able to give hopefully some information for everyone here to consider of our way forward. Thank you for taking the time. Best of luck to your Eagles there in Pennsylvania, and we really appreciate it.
You're welcome. Good luck to everyone.
Thank you.
Thank you.